social workers and helps with the Ombudsman program, Medicare counseling, and caregiver support program, and a lot of other things. She wears many hats, and you'll get to hear from her later in the program. And then on the back table here, Charlene and Amy and Kristen that just came in. Do you mind waving, Kristen, too? These three ladies you'll see if you go to the Tooele Senior Center or the Grantsville Senior Center. And we offer some services out in Wendover too. So you'll see these familiar faces at some of the activities, the classes, the events. Welcome, come on in. Through our aging services. So we're all staff here. And someone had asked, do we offer, what got us to offer this class on Alzheimer's disease? And we've actually been offering educational classes for the 11 years that I've worked here. So for a long time on a variety of topics, but dementia is always a common topic that we provide information and education on. In our county, Alzheimer's disease has been in the top 10 leading causes of death ever since I started working at the health department. They do an annual report and list the leading causes of death in our county. And Alzheimer's disease has been in the top 10 ever since I started working out here. And so it is something to be aware of, and the numbers are increasing. And that will be talked about a little bit tonight. And you've heard me maybe use the word dementia tonight and Alzheimer's, and I am excited to have an expert here to tell you kind of the differences in those terms and provide some other information for you. Kate is a gerontologist and a certified dementia practitioner with 20 years of experience in dementia care and family caregiver support and long-term care in the long-term care industry. At the state of Utah Division of Aging and Adult Services, Kate serves as the program manager for the caregiver support program and oversees the support offered to family caregivers of Alzheimer's disease and sorry, I'm going to take a step back. She oversees the caregiver support program for the area agencies on aging, which Tooele County Aging Services is one of those area agencies on aging. So that's a term, or AAA, that you may hear as you're working with older adults. So she oversees all the aging services, area agencies on aging throughout the state of Utah. And she also serves as the program manager for the Alzheimer's disease and related dementias program, which seeks to improve the support to those affected by dementia and enhance dementia services across the state of Utah. She's published articles, written numerous trainings on dementia topics for the Alzheimer's Association and various long-term care companies which she has worked for. And then as a gerontologist and a caregiver herself, Kate is devoted to supporting and advocating for older adults as well as caregivers throughout Utah. Kate received her bachelor's degree in psychology from the College of Wooster and a master's of gerontological studies from Miami University, and both of those schools are in Ohio. So we are glad that she's in the state of Utah, and we appreciate her sharing her expertise with us and driving out here to Tooele County to be part of our Answers About Alzheimer's series. So thank you, Kate, and I'll let you take it away.
Okay. Oh, can I steal that back?
All right, so that one around your neck.
Okay. I have to remind myself how this works.
And then that one on your
on this
pocket.
side. Okay. Perfect. Thank you. Okay. I'm so worried I'm going to trip. I have everything hooked up. Okay. How's that? Can we hear? Is that okay? A little bit closer? We're all right? Okay. Okay, closer. Okay. Okay. I wonder. We'll try that.
I didn't check the volume.
Oh.
Sorry.
Oh, there we go. How's that?
Better.
Better? Okay, you're going to hear me breathing now. Goodness, it's so loud. Okay. Hi, welcome. Thank you so much, Sarah and Amy and Lisa and team for the invitation to come. It's always good to see you guys. So, as Sarah said, my name is Kate Netterostic, and we're through this series about dementia. We're going to cover a lot of topics. So today, I'm just going to do a review, kind of a basic overview of dementia. But if you have questions on things that aren't on this slide, we can talk about it as well. So this is what we're going to get into today. So normal aging versus dementia. That's important to know what to expect as we age and when to be concerned. We're going to talk about different types of dementia, the warning signs, what the diagnostic process looks like, current medications, risk factors, and then ways that you can reduce your risk. Does that sound good? Okay. So as we get to these different slides, feel free to ask questions about these topics. And like I said, if you have questions that are not about this, that's fine. We can get into it. Okay, so when I start talking about normal aging, most people clue into memory, and they're super worried when they notice some changes within their memory. So let's talk about that first. So I like to describe your memory center in your brain, or your hippocampus, that's the technical term, not the memory center, but I like to describe it as a filing cabinet. So your filing cabinet in your brain, all of the memories, all of the information you've learned over the course of your life, anything like that you have stored in your memory center, that's in your filing cabinet. And if you want to recall a memory, you simply open up that drawer, kind of find that file you're looking for, pull that out, and you've recalled that memory, okay? So some of us have small memory filing cabinets, some of us have larger ones. What's the difference? Age. So someone who's, let's say, 60 years old is going to have a smaller filing cabinet system for their memories and all of this information that they've learned over the course of their life. They're going to have a smaller filing cabinet system than someone who's 90, right? Because that 90-year-old has 30 more years worth of life and information and memories that they've stored in their filing cabinet, okay? So what is normal as we age is that it takes, the older we get, the longer it can take to find those specific memories that we're looking for, okay? So again, someone who's 90, 30 more years worth of data to sift through than someone who's 60. So it makes sense that it would take that 90-year-old a little bit longer to find what they're specifically looking for than the 60-year-old. Does that make sense? Okay. So that's perfectly normal. Perfectly normal as we age. That recall takes a little bit longer. Okay? In a second, I'll talk about what happens when dementia impacts your filing cabinet. But let's keep talking about what's normal as we age. So what can happen as we get a little bit older is on occasion, we can have trouble remembering people, places, things like that. So for example, this happens to me pretty regularly. I don't know about you all, but if I know a person from one location, let's say I know somebody from work, and then I see them in a different setting, like the grocery store or the movie theater or something like that. It might take me a second to realize when I look at them, I think I know you, but I'm not, you're in a different space than I typically see you. So it takes me a second to kind of connect the dots, right? Normal as we age. Or you're driving somewhere. This looks familiar. I know I've been there, but it takes you a second to kind of remember that. That's okay. What we can also do is forget an appointment here or there. Or we misplace an item. My thing that I tend to do is, what did I walk in this room for? Does that sound? Yeah. Okay. Perfect. I'm not alone. So what did I walk in this room for? And in order to figure it out, I have to turn around, go back through the doorway, and then enter this magical realm again. You know, when I come back through the doorway, then it kind of, sometimes I can get it, right? Okay. Or let's say you miss a payment, you forget what day it is, but you remember it later. So for me, again, I'm telling on myself today. Let's say there's a holiday on a Monday and I'm off, I'm not working all day on Tuesday, I think it's Monday,
Yep.
right? Okay, but I can get myself back on track, right? And I can find that item that I misplaced. And another thing, so for me, if I'm not sleeping well, sometimes I have difficulty finding the right word that I'm looking for. But I can usually describe it or use another word that's very similar. So eventually I get it. So again, all of these perfectly normal, okay, as we get a little bit older. I want to show you some PET scans so you get an image of kind of what I just described. So this is the PET scan of a 20-year-old, and oh, that doesn't work on there. So I'm gonna come over this way. Okay, so the red, orange, and yellow areas of the brain are your most active areas of the brain. That's where that's where the most activity is happening. And then the blue, purplish, darker areas of the brain, that's the area where there's less activity, okay? So this is what a 20-year-old brain PET scan looks like. And here's an 80-year-old. What do we think?
I'm getting there.
Pretty similar, right? We don't see much of a difference. I would point to it with my pointer, but it's not working, so I'll use this pointer. So just a little, what I see, a little difference in this area, right?
And up above.
Up above a little bit?
Yeah.
Yep.
Up there where the blue comes down.
Uh-huh, yep,
That is
Yep.
also,
yeah. So this area, what do you think that area is?
memory.
That's your filing cabinet. That's your hippocampus. That's the fancy word. Your filing cabinet is the word I tend to use. Yeah. So the difference not much difference between a typical like 20-year-old and a typical 80-year-old, but the difference we do see accounts for these changes on this slide that I talked about, right?
Yeah, this is
Okay. That's you? Okay. Star that page for you. Okay. Let's talk about delirium. And then we're going to get into dementia. So delirium, when folks are experiencing delirium, a lot of folks think that's the onset of dementia. So what delirium is actually, here's your definition, the sudden onset of a temporary state of confusion. So keywords I have bolded: sudden onset and temporary. Okay? Dementia is progressive. It is degenerative. It does not stop. Delirium is a temporary state. So what causes delirium? You've got a couple examples here. So what I tend to see is when somebody is taking a new medication and that medication interacts with what they currently are taking and they have a bad experience. They see confusion. They're disoriented. They might even have difficulty completing specific tasks that they've done their whole life, like getting dressed or driving or something like that.
Or get lost.
Getting lost, there you go. What can also cause it, excessive alcohol or drug use, maybe a metabolic imbalance or thyroid abnormality, vitamin deficiency, things like that. Also, what we tend to see with folks that are a little older is infections. Urinary tract infection is a big one, or some kind of upper respiratory infection. So as an older adult, infections can really throw you for a loop. So we tend to see, when someone is experiencing an infection, we tend to see these symptoms that look very much like dementia, and then we get really nervous, right? So delirium is considered like a faux dementia or a false dementia or pseudo dementia. That's all ways that it's referred to. But if we can identify what the underlying problem is and then fix that underlying problem, the symptoms will go away. So for example, in my long-term care days when I ran assisted living buildings, and I would have a resident who one day is very, very different, and she's having difficulty putting her words together and expressing herself, getting down to the dining room for meals. We know there's some kind of delirium or something is going on. So we'll do some testing. We'll look at in her chart. Did she see the doctor recently? And was there a medication change? And if that's what it is, we contact the doctor, switch it back, and those symptoms go away. Or another big one that I tended to see is a urinary tract infection. So we'll test for that UTI, realize that's what it is. Now we introduce some antibiotics, and they go back to their quote unquote baseline, their normal baseline. Now it takes a while to get back to your baseline. So I usually give a couple weeks to see how that person kind of levels out before I get concerned about a permanent, change. Okay? So that's delirium. Questions so far? Mm-hmm.
How long can the temporary state go? Let's say you don't realize one of these things is happening. Let's say they've got a UTI or there's something going on, a deficiency. How long would that go, and would it progress by means of, would the delirium get worse or?
Yeah, depending on what's going on, you could see, if there's an infection, that could become a real issue if we're not treating an infection. So then you think about, those kind of side effects and issues that,
So you would probably see
Yeah.
other signs in addition to just the delirium if it is one of these situations.
If it's one of these situations for delirium, you're going to see very similar symptoms to dementia. So you're going to see that increase in confusion, you're going to see difficulty with language, difficulty with problem solving, those kinds of things. Yeah, go ahead.
Sorry, the thing else that Kate mentioned in emphasized was the onset tends to be more sudden. So if it's more of a,
Yeah.
wow, yesterday or 2 days ago when I talked to Mom, she was okay, but today.
It's usually a pretty obvious.
Yeah.
More sudden.
Yeah. Now, if this is somebody that you don't see very often, that would be a little harder to notice a difference. But if you're talking on the phone with them on the regular, and then all of a sudden they're having challenges, then it's most likely a delirium.
I just noticed with a lot of older people that their sense of smell is diminished. And so where if they're living alone, they might not recognize that they have a urinary tract infection because they have a diminished sense of smell. Where if somebody else is around, sometimes they will be like, oh, there's definitely something going on here.
Yep.
But that to me, I think is a common thing that people go untreated for quite a while without other symptoms.
Some folks are just prone to infections, and if they've dealt with UTIs, like I have a friend that I went to college with who regularly got UTIs, and so she was on medication to kind of stave that off. So if that's something that's normal for that individual, then the healthcare provider can deal with that. But yeah, if it's something that's not normal and we're seeing a drastic change, then we start digging around and trying to figure out what's causing this change. Yeah.
I just recently had a friend that passed away in 3 days from a UTI.
Oh, I'm sorry.
And she was 83.
Oh,
And
goodness.
She seemed such a good health. She was the caregiver of my really good friend that had a lot of heart trouble. And
Okay.
she seemed in perfect health. And then in 3 days, she was just gone.
Yeah. Oh, I'm sorry.
It was UTI.
Yeah.
And I had no idea that that could cause death.
Infections can really wreak havoc. Yeah, for sure. So if we see a quick change with somebody, doesn't mean it's dementia, but there is something going on that we do want to address, okay? But it can absolutely look like dementia. So that's what I used to see a lot with my clients or my residents in long-term care, is they would have a drastic change and the family thinks they went from, no dementia to like late stage dementia like that. And that's not how that works. But so that's delirium. And then let's talk about dementia. So here's your definition. So dementia is an overall term that describes a wide range of symptoms associated with a decline in mental ability. Here's the key: severe enough to interfere with daily life. So dementia is progressive. It is degenerative. Right now, there's no way to stop dementias. So now, while each type of dementia looks a little different, and some different dementias will have different symptoms as kind of their primary symptom or their primary concern, in order for it to be considered a dementia, there has to be at least two of these core mental functions that are significantly impaired. So it could be somebody could have impairment with memory, and reasoning and judgment, or challenges with memory and communication and language, as an example. Okay, so dementia is not a disease in and of itself. It's not a diagnosis in and of itself. It's this term that we use. We often refer to it as an umbrella term because it's this overarching term that describes the symptoms that you're seeing with that type of dementia. So the specific diagnosis is not dementia per se, but it's what type of dementia. Okay, so here's some examples. In keeping with the umbrella theme, we've got some raindrops. So Alzheimer's disease is your most common type of dementia. That makes up 60 to 80% of all types of dementia are Alzheimer's disease. Then after that, I would say frontotemporal degeneration, or FTD, Lewy body dementia, and vascular dementia. Those are your next most common, but they are only in about 5 to 10% of all dementia cases. So you can see that Alzheimer's is that big daddy dementia there that majority of people experience. But you've got all kinds of other dementias and many, many, many more. And then what can also happen is folks can have more than one type of dementia at a time. So we can see Alzheimer's disease and vascular dementia, or we'll see FTD, frontotemporal degeneration, and Alzheimer's disease. And each of those, of course, come with their own challenges. Okay?
So you can see a Lewy body dementia and Alzheimer's at the same time?
Mm-hmm. Yep. Yeah, they each look a little different, a little unique, and they have different kind of characteristics. And I'm going to show another, is it this next slide? Let's see, because I can't tell. Nope, it's not. But I'm going to show a slide in a little bit where you're going to see more PET scans, and I can show you what those different types of dementias look like with the scans. Yeah. Any other questions about this? Yeah.
You said there's no way to slow the progression of it. Are you going to talk about medications?
I am going to talk about medications. There's no way to stop dementia right now. We do have some brand new medications that can slow the progression of the disease process, but those are only for a specific type of dementia and a specific stage. So I will talk about that a little closer to the end. Mm-hmm. Yeah. What? Mm-hmm. Yeah.
What would be sundowners?
Sundowners. So sundowning is what we describe what happens when a person with dementia, when it gets towards the end of the day and they become more confused and disoriented. That's what we call sundowning. So as the sun goes down, we see this ramp up of confusion, agitation, restlessness, those types of things. So that's sundowning. It's not a diagnosis, really. It's not a disease in and of itself. It's just some symptoms that kind of come along with the disease process. And so what can happen as a person develops dementia, so we have millions of neurons in our brains. And our neurons work to communicate with each other and tell our bodies what to do and how to do it. Okay? And if somebody were to ask me that question that you asked me, my brain is going to process that using my neurons firing and sending messages to each other to process that question and then formulate a response. And then to formulate the response, my brain has to tell my mouth and my voice how to answer that, right? Or if I want to take a seat, I have to walk over here after identifying where the chair is, right? Grab the chair, pull it out, walk in front of it, lower myself, bend at all the things, lower myself down and have a seat, right? That's a lot of steps that are pretty automatic because we don't really think about it. But what happens with dementia is when those neurons are impaired, they're actually killed by the disease process. And so you have fewer neurons to communicate and send messages. And so it's very similar to, I like to use this analogy of our favorite time of year, construction season, right? When you're driving to get here, for example, and the route you would normally take, or the route that GPS tells you to come, doesn't realize the road's out. There's construction going on, and you have to be rerouted a different direction. So you can still get here, but it takes a little bit longer because you're going in a different direction. So that can happen with neurons, is as you're asking me that question and I'm formulating a response, I'm kind of processing that. What can happen is I lose a couple neurons, so I've got to work harder to process that and make sense of what was asked. And eventually I lose enough neurons that I can't make sense of that question that you asked me. Or I can understand it, but I can't respond. My brain isn't telling me how to respond. Or I want to go sit down, but my brain isn't identifying the chair. You say, let's come sit on this chair. What's a chair? That's not making sense to me. So when all those neurons are affected, the longer someone has dementia, the more and more neuronal death happens. And then those messages, that communication struggles to get through. So when you ask that question, it's almost like you can watch someone's wheels turning. They're trying to process that and make sense of what they were asked, and then formulate a response. And eventually they just have difficulty, and that message, all the roads are out, and that message isn't getting through. So that can what happen. Yeah?
You should always keep that visual.
I've been using that for about 20 years, a little over 20 years. Yeah, so it's a long analogy. I'm long-winded. You'll pick up this if you haven't already. Long-winded, but I think it makes a difference. So what happens with sundowning is I'm trying my best to make sense of the world around me and to take all these clues, all these cues in my environment to tell me what it is I'm supposed to do, who you are, how do I know you, all of these kinds of things. And my brain, because it's a damaged brain, gets really, really tired. It's working on overdrive to try to make sense of everything. And so what happens with sundowning is as the day goes on, I'm even more tired and even more tired. And so I can struggle because I have more confusion, I have more disorientation because my brain is just exhausted. So that's sundowning really. And what can happen is you can have this burst of energy where a person, it's towards the end of the day. What do we typically do at the end of the day? Maybe I need to head home from work. I've got to get the kids off the school bus, whatever it might be. I have this feeling of I need to do something, but I don't know what it is I need to do. And so they'll wander and what we call exit seeking and kind of get themselves in trouble because they wander away. So that's sundowning. Does that make sense?
Yes, thank you.
Okay. Do you have a question?
My brother has Lewy bodies dementia,
Okay.
and when I listen to the doctor and I listen to my sister-in-law, I kind of think of it as like he was crossing the road that he's crossed 1,000 times. It's like a light switch turned off and his legs turned off.
Mm-hmm.
Flat right on his face.
Mm.
Is that what we're kind of looking at too? Is the dementia can turn off switches to the brain, like turn off that light switch for a little bit.
Mm-hmm.
I'm saying your
Yeah.
leg doesn't move.
Yeah,
And
that's another
it's
good
gonna go
analogy.
to your heart or something.
There's another good analogy with the light switch. And I've heard folks use the light switch before or use like the window shade. Some days the shade's open or some days the light's on and some days the shade's closed or some days the light's off. Yeah, so with dementia, every moment can be different. And so you can have we all have really good days, right? With dementia, you can have good days as well, where everything's kind of firing, all your neurons are firing. It's just a really good day. And then other days, in even moments, hour to hour sometimes, something happens and that brain isn't processing very well.
So is the cause of death eventually where, in my analogy, where eventually like the light switch goes to your heart or it goes to something,
Yeah.
where it's vital to take care of you, or it causes, your immune system to shut down, you get sick, pneumonia.
Mm-hmm.
Is that?
Yes.
Is that a good
Yes and yes,
description into my
it
brain?
is. Because what happens, it's not that, I've heard people say you forget to breathe, you forget to eat. It's not that you forget, It's your brain can't tell you how to do that anymore. Your brain is so damaged. So when somebody passes, unless you have, like a stroke in addition to dementia or, some kind of accident, most folks with dementia will pass from, as their brain is shutting down, they're less mobile, and so they become bedridden. That can cause upper respiratory infections, things like that you mentioned. Or the person will lose that ability to eat, and so they're not eating, so their body will just shut down because they're not eating. Yeah, it's a good question. Any other questions?
Is there an age?
Is there an age?
Yeah, I just want to point that out.
So because Alzheimer's is the most common type of dementia, that tends to happen 65 years of age and older. But there is a younger onset version of Alzheimer's disease that happens below, under the age of 65. Then you have some dementias like frontotemporal degeneration that tends to hit in one's 40s or 50s. So it just depends. Most folks, if they develop a form of dementia, will be after the age of 65. So age is the greatest risk factor of specifically Alzheimer's disease, but most dementias. But there can be other things. So what do we have here? Okay, so vascular dementia, that's when you have a stroke in your brain, somewhere in your brain, or multiple strokes. So based on heart health, based on family history, a stroke can happen anytime. I've known folks to have them in their 20s and 30s and 40s. So if you have a stroke that's severe enough, that can cause vascular dementia. Where is it? Traumatic brain injury, TBI. So folks who are playing football or soccer or rugby or wrestling, or you got into a car accident, or you've fallen a number of times and hit your head, that can cause enough damage to then create a dementia. Yeah. So it really depends.
Is that one later in life? Like if they get it when they're in their 20s or something, later in life, a traumatic brain injury?
It depends. It depends on how severe it is, and it depends on how many you have. Because actually, this is interesting. I watched a documentary. I can't tell you what the name of it is. I forgot. What's it called? What was it called? Anyway, I saw a documentary of so he was in his 20s, and he was in the NFL and had a traumatic brain injury and dramatic change in behavior with him. Mm-hmm. Yeah, confusion, disorientation. He fell victim to scams, financial scams, things like that, because he wasn't processing properly. He wasn't using reasoning and good judgment.
And
Yeah,
like
so it depends.
Body dementia can cause vascular dementia. It can cause other things. Result into these, or
I don't know that one can cause another one, because you can usually, if somebody's got Lewy body, that there's something specific you're looking for in the brain. They're called Lewy bodies. Dr. Frederick Lewy is the one who discovered these deposits in the brain, so they named it after him. But those look very specific to Lewy body dementia. Very similar to Parkinson's disease, though. With Lewy body and Parkinson's, you have the tremors and the shaking. So you'll have some very similar symptoms. And then you have like Korsakoff syndrome. So Korsakoff syndrome, Wernicke-Korsakoff syndrome, the majority of people, this is caused by a deficiency in thiamine, and usually what causes that is excessive alcohol use. So if we do have somebody that over a long period of time drinks alcohol excessively, they can develop Korsakoff syndrome. So it's a different type of dementia.
I've heard with that with the Wernicke's encephalopathy.
Uh-huh.
Would Wernicke's encephalopathy happen first and then the Korsakoff syndrome?
They can happen independently, or they can happen together.
Really?
Yeah. Mm-hmm.
you can have multiple of these, like you said, at the same time. So
Yeah.
my brother could have Lewy body dementia and vascular dementia, because they noticed he's starting to have more strokes.
Yeah. Yeah, so it's not that Lewy body is causing vascular, but he also has vascular issues, has cardiac issues that are causing those issues, right? Yeah. Yeah. Good questions. Okay, any other questions? Okay, I can't see any time I can't see much on my screen, so you just shout at me. I can go for weeks, so you got to cut me off at some point, okay? Okay. Okay, let's talk about warning signs. Let's talk about changes that we see with somebody with dementia, okay? So if you know someone with dementia, this will look familiar. If you're worried about somebody that you think may be developing dementia, these are some warning signs to think about. Actually, before I do that, one of your handouts is this fun one with the brain at the top. Now the different lobes of your brain aren't this color, but I did that for funsies. So what I like about this handout is you can see your frontal lobe, parietal lobe. So based on these different lobes, you can see here the next column what those control, what the functions of those lobes do in a healthy brain. And then when somebody is injured in that specific lobe, that'll tell you what impact that will have. So, for example, your frontal lobe that's your emotional center. So when somebody has frontotemporal degeneration, guess where that happens in your brain? In your frontal and your temporal lobe, right? We're really, really good at names. So your frontal lobe, when somebody with FTD when someone develops FTD, they have difficulty regulating their emotions. So they can overreact in situations where you might disagree about something and all of a sudden they're very upset and can become really agitated, or they can underreact in situations. They also have difficulty with judgment. And so, for example, one of the clients or one of the colleagues that I work with, her husband developed FTD. And when they were at the store going shopping, he would take items and put them in his pockets because he thought, oh, that looks great, I want it, that's mine now. And so she would have to warn the cashiers and the team at the store, if we get home and he's taken something he's not supposed to, I'll bring it back, don't worry. So things like that can happen. So I love this handout because it gives you a sense of, if you know where there's damage in the brain, if you've seen those kind of brain images, and you know there's damage in the temporal lobe or the parietal lobe or something like that, this kind of helps you to make sense of why you're seeing what you're seeing, why you're seeing a change in behavior. Okay? And then if you look at the cerebellum and the brainstem, when dementia progresses, and so for specifically Alzheimer's disease, starts in your hippocampus, right, which is your temporal lobe, but it spreads out and it will encapsulate the entire brain. So eventually when it gets to your cerebellum and your brainstem, what does that control? Your balance and coordination, which is why then you're not ambulating, you're not walking anymore, you're either sitting or you're bedridden, and then breathing, heart rate, alertness, and consciousness. Okay? Does that make sense?
So is this progressive in this order?
No.
Okay.
No. It's just by lobe. Just,
And it varies by disease, actually.
yes. Yeah.
So with Alzheimer's disease, it starts in one spot, frontal temporal, then another spot, Lewy body, another
Yeah.
spot.
Yeah.
So you kind of see the symptoms based on where the disease is impacting the brain.
Yeah. And then you have, do I have it on here? Yeah. Then you have one like posterior cortical atrophy, posterior of the brain, the back of the brain. That's in your occipital lobe. That hits your occipital lobe. That's your vision. So I had a client when I worked at the Alzheimer's Association who had posterior cortical atrophy. And she kept saying, I'm going blind, I'm going blind. And it wasn't per se that she was going blind, it was her brain couldn't process and make sense of what she was seeing. So she couldn't drive anymore. She had a friend drive her to the support groups that I ran for folks with dementia. And she would have difficulty with lighting. If there wasn't enough light, it was difficult for her to see certain things. So she had to be very cautious because her brain was kind of playing tricks on her. So, for example, so this chair is green, the seat of the chair is green, the carpet is green as well, but it's not exactly the same. But what can happen is if you have something, two colors too similar, my brain has difficulty telling me where is the seat versus the floor. Am I going to end up on the seat or am I going to end up on the floor? Because I can't aim my derriere properly to figure out where the chair is. So your brain can play those tricks with you for sure. Yeah. Okay, so I wanted to explain that handout. Okay, so these changes. Let me get my next handout so I know what I'm talking about. Okay, and this kind of goes along with this 10 warning signs document from Alzheimer's Disease International. So you can look at either. But this is the slide that talks about the cognitive changes that we will see with a person with dementia. Again, each dementia is a little bit different. So you're not going to see all of these in every single person. But so for example, memory loss is not the primary symptom or concern with frontotemporal degeneration, as an example, okay? But what we tend to see, challenges with communicating or finding words. So years ago, when I was in the long-term care industry, I was a dementia specialist for a company, and I covered 4 buildings, or I lied, 4 states, big difference, 20 buildings. I was like, that sounds like an easy job. 20 buildings in 4 states, Ohio, Indiana, Michigan, and Illinois. And I would travel around and visit these buildings and kind of help the teams and provide training and things like that. And I walked into this one building in Kokomo, Indiana once, and the whole building, individuals with dementia. And I walk in, and there was a nice lady sitting over to the side, one of the residents, on the couch, just kind of people watching, right? So I went over and I said hi to her. I said, hi, how are you doing today? And she gave me the biggest smile in the world, and she said, I hate you. and I thought, oh, that's the nicest someone's ever told me that before. But I knew what she was going for, right? Her tone of voice, her facial expressions told me she didn't mean hate, but that's the word she could access at that moment, right? So I didn't act like I wasn't offended. I understood. I put 2 and 2 together, and I thanked her. I've never thanked somebody for telling me they hated me before, but I did for that lovely lady. So just an example of challenges with communicating, okay? Confusion or disorientation is another something that we'll tend to see as well. Declining coordination and motor functions. Again, can your brain tell you how to pick up this water and how to open up the lid and how to take a drink and how to swallow it so that it goes down the right tube and not into your lungs, okay? Issues with reasoning or problem solving. There is no reasoning. There is no reasoning with a person with dementia. It's very difficult because their thought process isn't like ours, okay? Memory loss, which is usually noticed by someone else. So they can notice a change in themselves, but when it's significant enough that someone else is noticing it, then that's an issue.
A question for you though.
Yeah.
How can you as an individual, for example, I'm a single widow person, okay?
Okay.
How can you protect yourself from being falsely categorized or diagnosed by family members and put you in these situations? You see where I don't know if I'm getting myself right. You know, they say, oh, your memory loss, and so, or this or this or this, you know, and it's really not occurring, and so they start doing things.
So I like to use science and facts. And so I would recommend seeing your doctor on a regular basis, or whoever it is we're talking about, to have them see their doctor on a regular basis and have what we call, if you have Medicare, where do we put it? Here we go. This card talks about the annual wellness visit that you get through Medicare for free. It's a preventative health check, right? There's a cognitive aspect to the annual wellness visit. So does that sound familiar? Have you done annual wellness visits?
Oh, yeah.
Perfect. Does it sound, does like a cognitive piece sound familiar? Usually it's, I'm going to tell you 3 words, repeat them back to me, and then I'm going to distract you, and 10 minutes later, what were those 3 words again? Right? Or count backwards. Oh, I'm not going to be able to do this one ever. Count backwards from 100 by 7s.
No.
Start practicing. Or what about spell the word world, WORLD, right? Spell that backwards. There you go. Amy's got it. DLROW, right? So in order to spell that backwards, you have to spell it first, forwards in your head, and then hold on to those letters and go backwards, right? That's a lot of processing to do that. So what was the answer? Oh, I was like, I'm not going to tell you the answer. It could be any word, but world is a good one. Rhinoceros, there you go. I give up. Just diagnose me with dementia. No, so what should happen during your annual wellness visit with your doctor is a cognitive screen, a cognitive test, a brain health checkup. So what you're doing is, if you're doing that every year, and ask, if you don't think that's happening, the cognitive piece of the annual wellness visit, ask about it. But there's different screening tools that providers can use, and that will give you a baseline. And then every year, you just kind of see if there's been a change. And so if we start to see some changes, then
So if you're
we should be
doing
concerned.
those, but you want to protect yourself, and I'm not labeling my children, but I have seen this in families where they will label you as this and put you in that category. How can you scientifically get them involved and say, hey, no, I don't have this because A, B, C, D.
Yeah.
But you're saying I have this A, B, C, D. So
Yeah.
you can protect yourself as an individual
Yeah.
from somebody else slamming you in that category.
Right. So in a bit, I'm going to talk about the diagnostic process. And so you can go to a specialist and ask for an evaluation. Usually you start with your primary care provider. We'll get into that in a little bit. So let's hold on that. I will say, from a legal standpoint, even if, let's say, your children were your power of attorney, that doesn't take over for your decision making if you're still able to make decisions. So even if you have somebody as your power of attorney, that's just if so let's say I'm a power of attorney for my parents, and they're to the point where they're tired of dealing with finances and whatever, and they say, Kate, you're the power of attorney, you're up. Take care of it. That's their job, or my job, right? But if I make a decision that they don't agree with, they override any of that. So I'm just there as the power of attorney to help in those situations. Guardianship is where that's a very legal process where you're going to the courts, and someone has to be deemed incompetent before somebody else can make changes to their finances or their health care or anything like that. So that's very different, and that's a lengthier process where if I'm saying you're incompetent, you're not able to do these things, I would file either to be your emergency guardian, and then you get an attorney and I get an attorney, and you are evaluated by a couple doctors, and they determine whether or not you're competent, and then that goes to the court, and the court says yes or no, you're fine on your own. So that's a legal process, and that's difficult to fake, very difficult to fake. Yeah.
And just because you're diagnosed with dementia doesn't mean you automatically lose your ability to make decisions. You can have it for years and years and years and still retain that
Yep, very good. Did everybody hear that? No? So just because somebody has a dementia diagnosis doesn't mean they are incapable of making decisions. So that can, we see, I mentioned dementia is progressive, it is degenerative, so eventually it will become an issue. But again, I ran support groups for people with dementia who were newly diagnosed and wanted to learn about their diagnosis, and they came together with other folks with dementia, and they shared their stories, and they asked about legal planning and financial planning and what do we need to work on, and some of them still drove themselves to those meetings. Some of them knew they weren't safe to drive, and others were still safe. So there's a timeline here. Not everything happens right away. All those changes don't happen right away. Yeah, good point. Okay. Okay, poor visual and spatial abilities. I think I mentioned that with the chair. As an example, problems handling complex tasks like finances. This is where folks can easily become victims of financial scams. So I have a very good friend who's a little younger than I am, and her father has mild cognitive impairment. So that's not always a precursor to dementia, but most of the time it is. And she had to take him to the court and become his conservator. So that's just for finances. So she manages his finances for him because some scammers got a hold of him, and his Social Security checks were being deposited into their accounts. And he was sending money left and right to them whenever he had it, because he thought he was making deposits on a larger withdrawal, on this money that he was going to get, right? And he almost, his power was turned off because he wasn't paying his bills, and he missed several mortgage payments, and so the family had to come in and fix all of that. Yeah. Okay. Trouble with planning and organizing. So if somebody's still working and they're developing dementia, as one of those younger onset types of dementia that can see a difference in their work, or just things around the house, tasks that they're trying to do around the house. Okay, we've got another slide. This is the psychological changes that we'll tend to see with dementia. So agitation, anxiety, depression, hallucinations, inappropriate behavior, paranoia, and personality changes. And so what can happen here, again, think of your neurons, and they're trying to communicate, they're doing their best to make sense of the world around them, okay? So let's say I have dementia, and it's towards the end of the day, and it's dark outside, and I've got the lights on in the house, and I'm looking out the front window. The curtains are open, blinds are open, and I'm looking out the front window. And because of that situation, it's dark outside, it's light inside, I see reflections of people behind me in the room, of my family, of me and my family. But because my brain is damaged and not making sense of that properly, I might say, somebody's outside. Who's this in the yard? Get out of here. And I might run outside and start arguing with somebody who's not there, because I'm trying to make sense of why I'm seeing a bunch of people in the window. Okay? Or as the sun is moving in the sky and I'm seeing shadows, the shadow of a tree kind of move, I might say, somebody's behind that tree. Who's here? Let's call the police, So any of these things can happen. If I am trying to help a person with dementia get a shower, but they're not processing properly, right? And I'm taking them into the bathroom, and I'm closing the door. The water's coming on, and I'm trying to take their clothes off. That might spark agitation. What are you doing? That might spark paranoia, fearfulness. I don't know who you are. Why are you doing this? Get away from me. And now that person's going to try to protect themselves, right? So you can see how things get jumbled up because of what's happening in the brain. So it's not that the person with dementia is giving us a hard time. They're having a hard time, and they're really struggling to make the best out of this situation and to make sense of what's happening around them. Okay? Does that make sense?
Or they don't even know it's occurring,
I'm sorry?
or they don't even know it's occurring.
Yeah, yeah, yeah. The further someone is in the disease process, the less they tend to put two and two together, and they just might let you do whatever it is you need to do because they're not realizing, or they don't know how to respond. Their brain can't tell them how to respond. So I have inappropriate in quotations. This is something that I heard a lot when I was in the long-term care industry. He's being appropriate. They exhibited inappropriate behavior. But if my brain is damaged and I'm doing the best to try to understand what's around me and who you are and what we're supposed to be doing next, and if I have this 18-year-old nurse aide taking me into the bedroom and, we're turning the lights off and we're closing the door and taking my, trying to get me into pajamas, what do I think's about to happen?
She's gonna hurt me.
Could be. Could be. I was just visiting Christy, who you're going to see next week. Christy's on my team, and she and I were called to a long-term care community in Orem. I think we were Orem, Provo, one of those. And we met with the entire team to talk about this one resident who they had difficulty changing her brief every single time. Turns out she had a history of sexual assault. She was sexually assaulted from a young age. And so that's where this is coming from. So yeah, the thought might be, you're here to hurt me, or the thought might be, we're going to bed together. And so then if I think that's what's going to happen and I'm touching someone and they don't like that, is that inappropriate? It's to be expected. Yeah, it could be to be expected. So we've got to think of how to set them up for success. Yeah. Okay. Does it make sense? Okay. So back to the filing cabinet, right? So what can happen with dementia from a memory standpoint is as dementia, specifically Alzheimer's disease, is attacking that memory center. Again, we've got all these files in our drawer. And what can happen, it's almost like the bottom of that drawer starts to disintegrate and those files are falling through and they're not stored there anymore. And this happens with your most recent, most current memories and works its way backwards in time. So that explains why someone's long-term memory is much, much stronger than short-term, than what happened yesterday or what happened a couple of weeks ago, right? It's because that's kind of how the disease process works. So if I have dementia and someone comes to visit me yesterday and I want to put that memory of that visit in my filing cabinet, in that file folder and in the filing cabinet, but the bottom of that drawer is not there to secure it, it's not being stored, right? So today, when you ask me about my visitor yesterday, nobody visited me yesterday. What are you talking about? I haven't seen this person in years. What are you talking about? Right? Does it make sense? Mm-hmm. So long-term memory is something that can still be accessed because the disease process hasn't impacted those drawers yet. Okay? So when somebody with dementia, when somebody, I'm breaking everything, with dementia, let's say my mother has dementia and I walk in to see her and I say, "Hi Mom, it's Kate. It's good to see you today." And in her mind, she's accessing only memories from in her 20s and maybe 30s. Do I look like, and she had 4 children. She started having them, I think, at 35. So do I look like I could be her daughter? If that's the time frame that she's living in? Nope. So she might mistake me as her sister. Well, she doesn't have siblings, but she might mistake me as her aunt, for example, or a dear friend. Where they know, I know you're somebody I can tell that loves me. We've got this connection, but you can't be my daughter, so you must be this person. So you can see how people with dementia can confuse other folks. Or, there's no way you're my daughter. What are you after? You're lying to me. I can't trust you, right? Then that paranoia kind of happens. Okay? Does that make sense? Okay. Other questions? Oh, we're going to get into PET scans. Other questions before you look at that? Yes?
So is it worth having that conversation of, no, Mom, it's me? Or is it just, okay, you just go with it
Yeah.
and move on? Because I know you end up trying to do a lot of negotiating and reasoning, like you say, and they can't reason. So
Yep.
you're better off just backing off and going with what they're saying.
Yes. I say, first of all, next week, come back next week, because Christy's going to talk about communication and behaviors. Okay? So that's going to be a good one. But I say it depends on kind of where they are, because when I ran support groups for folks in the early stages of their disease process, they knew when they made mistakes, and they wanted me to help them with corrections and things like that. So you could ask that if somebody's early in their diagnosis, in their disease process, because it can be very helpful for them. But how do you know when it's not helpful? When you get a blow up, a pushback, something like that. Then you know correcting isn't the way to go. What I'm more concerned about is breaking trust with that person. And so I don't want to argue. I don't want to go against. So we call that joining their reality. Okay? Make sense?
Yeah.
Yeah. Now, as long as that person's safe, they're not doing anything really, really bad, then join their reality. I had a gentleman who had been an alcoholic his whole life, and so I think his diagnosis in my memory care neighborhood wasn't Wernicke-Korsakoff syndrome, but it probably was. It was just dementia, because the doctor didn't go into that much, digging to figure it out. But he probably did have Korsakoff disease, and so he would come, to me upset at the end of the day. I've got to get back on base. He was also in the military. I've got to get back on base. I'm going to get in trouble if I'm not there. Leo, are you kidding? You went AWOL? What are you doing? And so I would try to talk to him and let's get you a flight back and things like that. So I kind of entered his reality to calm him down. Don't worry, we've got a cot for you. And I started using terms, right, that he would resonate with. We've got a cot for you tonight. We'll get you back first thing in the morning. Something like that.
Kind of a separate back to
Yep.
the short-term memory stuff. Does time play into that? Total no idea of time. With my mom, it's my dad will tell her, okay, I'm going here, I'll be back. He'll be gone for half an hour, and in her mind, you were gone all day.
Yep.
Is this part of it,
Yep.
of the concept of time?
Yep.
You can't keep track of it.
Yes, and on this you'll see disorientation to time and place.
Okay.
Yep, so you're spot on, yes. So that's tricky because they're gone 30 minutes and they've gotten 10 phone calls. Where are you? You haven't been here all day. Or you've been gone for days.
Yeah.
Yeah,
Okay.
yeah, and that gets really hard. Yeah. Okay, let's look at some brains. Okay, so on the left, again, normal brain, and what we're looking for is those bright red, orange, yellow areas of the brain, the high activity levels of the brain. That's where your neurons are firing and they're communicating with one another. And then we're going to see, okay, so Alzheimer's, let's start with Alzheimer's. So there's your memory center, your filing cabinet, your hippocampus, in your temporal lobe right there. Okay, so you can see that the disease process has already started and is starting to spread out with Alzheimer's. So you can see the damage and the neurons aren't, that area is not so active. Okay, frontotemporal degeneration. You're seeing more issue in your frontal lobes and your temporal lobes. Okay, Lewy body. You can see that. And again, go back to your cross-reference here. Okay. So you can see this kind of the side and the back part of the brain. So your occipital lobe, your parietal lobe, a little bit of your temporal lobe, and that explains why you're seeing these different changes with your loved one. And then vascular dementia, depending on where the stroke was, or multiple strokes or something like that. This could look a little bit different with each person, but these are typical. You'll tend to see those images with each diagnosis. Okay? Yeah.
Is that how the types of dementias are determined, is through PET scans and then along with the symptoms?
Yes, and I'm going to talk about the whole diagnostic process in a little bit. So yes, that's part of it. Yeah. But you can see here, so the reason I show these pictures is because it's hard, like, if I were to come in here today and I broke my arm, and I have my arm in a cast and in a sling, you can see I have a deficit. I have an issue, right? And you're all lovely, wonderful, amazing people. You would open doors for me, and you would carry my things for me, and all of those things, right? Because you're wonderful people. Yes, you would. Okay? But folks with dementia don't walk around with gauze around their head telling you, this is where my issue is. This is where my challenge is. This is where I'm having trouble. I need your help and support. So I show you this so you can see really what's happening. Okay?
Will a doctor recommend having that done?
Mm-hmm. Yep.
Okay.
Yes. That's brain imaging right here
Okay.
on the 6th bullet point down.
Okay,
I had to count.
was just wondering because I had to, because the gentleman I care for, he lies to his doctor. So
Yeah.
I went in personally and had them put a note in when his next visit. I have been to his visits and he just looks at me like, you say one word, you know.
Mm-hmm.
So
He flies off the handle.
he flies
very
off
easily.
so I decided to go to his doctor's office and make a note that he
Good.
needs to check these other things.
Because they're not doing anything.
He's not doing
You're
anything.
talking about the wellness. not-
It can be pretty, I mean, people with dementia can cover themselves,
yeah.
right? We can all cover. Like if I saw somebody at the grocery store and I'm like, I'm not sure who this person is, but they are saying, oh, it's good to see you. I can put on a show and they think I know who they are. And then I go to the car, that's who it is, right? They still think I know them. They haven't, I
He
haven't,
just
right?
had a wellness check
Yeah.
and the guy's like, well, he forgot one word and he goes, oh, it's nothing to worry about. I'm
Okay.
like, well, this is
So
the
this
third
is where,
time.
this is where family and friends, when you can add, because people with dementia can cover
Oh,
them
yeah.
for themselves,
Well, that's
right?
why I want the doctor to go
Yeah.
deeper.
Yeah,
And he keeps, every time I go with him, it's like, because I am.
Nothing's wrong.
Nothing's wrong, nothing, everything's
Yeah.
fine. Well, it's not fine.
yeah.
But.
So I think
doctor
having the
also-
conversation with the provider ahead of time, like knowing they have an appointment coming up, and they can't per se share information with you unless they were approved by the patient to do
But I
so.
am also his
Caretaker.
his
Okay.
caretaker.
Okay, so they
just
might
like
share
her.
information with you,
Yeah,
but
well,
maybe not with others.
Yeah,
Yeah,
like him, or
Yeah.
like her.
Yeah.
Yeah.
I'm her,
She has
next to Kim.
power of
I got
attorney.
power of
Okay.
attorney over
For
her
me and him.
Okay.
So I go to the doctor and I can find out
Yes.
whatever I need to find out.
Somebody has to,
yeah.
because he has no family.
Most of what we see is the person with dementia or suspected dementia doesn't have power of attorney. They have family,
Well, his
and
family
or they're
always
concerned.
informed him.
Yeah, or they're concerned about somebody getting access to the medical records. And even if they had you listed as the caregiver, and yes, you can get access to medical records, he might take you off.
He won't.
Okay,
I know
let's
he
hope he
won't.
doesn't. Let's hope he doesn't. But it's happened.
Yeah,
And
I
so what can
understand.
happen is, in a typical situation, is the family sees or friends see these changes with their loved one, and the doctor isn't seeing it. Because again, the doctor's a short period of time, right? The doctor's doing their best. You got 10, 15 minutes to state your, case, and then you get on. So the doctor may miss some certain things. And just like any of us, people with dementia can rise to the occasion when they're being tested, and it's a good day and everything's firing and they're answering all the questions, right? So that can happen too. So what if this happens to any of you and you're at those appointments with this individual, maybe try to sit behind them and give one of these
I do that.
if you can, you know. But most of the time, what we recommend is contact the provider in advance of the appointment and say, here's what I'm seeing. Please look for this. Please ask about this. Please look into this.
Right.
That's the best way to handle it. Okay? And then also, don't tell anybody I told you, because then I'll get it from the patient, you know? So that's
Yeah.
typically what we recommend.
Okay.
And eventually it'll catch up to them. Yeah.
He has an appointment in November, so.
Okay.
We're
Okay.
good.
So here's the whole diagnostic process. So there's not one specific test that everybody can take to determine the type of dementia that they have. It's really a ruling out process, because especially I talked about delirium. You got to rule out all those things too, right? So we're doing a medical history. So your current past conditions, medications, family history, a physical exam is going on. There's also, that can be a neurological exam. We've talked about changes in cognition, changes in behavior, so they're going to look for that. That's another piece of it. Depression screen and mood assessment. Depression can absolutely look like dementia. Brain imaging, that's all that.
So why don't they just go to brain imaging right off? If there's a system.
Insurance,
Yeah, finances.
Yep. And you gotta, providers have to state their case of why they need all of this kind of stuff done. Yeah, I know. But you could do CT scans, you could do MRIs. These are PET scans, so that's another way to look. This is an interesting one, cerebrospinal fluid. So you can do a spinal tap and draw some fluid out of your spine. And so what happens is it's very interesting. This has an inverse relationship. So the more plaques found in your cerebral spinal fluid, the less in your brain. And plaques, beta amyloid plaques, are one of the hallmarks of Alzheimer's disease and some of the other dementias, along with tau protein. So these are different protein deposits that you'll see in the brain depending on the type of imaging that you do. So the person who has more plaques in their brain, which then is causing dementia, has smaller amounts of plaque in their cerebral spinal fluid. It's very interesting. Okay, so that's another way they can look. Blood test, because you want to rule out like thyroid abnormalities or vitamin deficiencies and all of those kinds of things too, because those can present like dementia. And depending on the type of dementia, if it's somebody who's younger than 65, we might do speech language assessments. We might do genetic testing as well. So it could be all of those things. Now, all of this starts with the primary care provider or your internist or whoever that is that you see. So the business end of dementia is absolutely in primary care, but then most of the time you'll also be referred to one of these specialists. So we have neurologists who specialize in the diseases of the brain and the nervous system. Psychiatrists, and these are the folks especially that they're very hard to fool, because they know what they're doing. But a psychiatrist who's trained in general psychiatry with additional training in mental health and aging, a psychologist who specializes in testing to assess thinking abilities, and then a geriatrician who specializes in the care of older adults and dementia. So I always recommend, if you're an older adult, to see a geriatrician as your primary care physician, as your primary care provider.
Is there an age when you start recommending that? Is that like 65 and above?
You could do 65 and above. You could start in the 50s. Yeah, 60. Yeah. Now we do have, though, a shortage of geriatricians. So find one quick. No, I'm just find one that you like and stick with them. But so my parents see geriatricians. Yeah.
Where do your parents live?
I'm sorry?
Where do they live?
My parents are in Utah. I mean, we've lived all over the world, but years ago, I told them, because of what I do, they got connected to geriatricians in Ohio and then Virginia, and then when they moved to Utah, geriatricians. Yeah. Yeah.
Definitely for you.
Okay. So does this?
I'm sorry.
You're funny. I love this group. We still good on time?
7:15.
Okay.
15 more minutes.
Okay, 15 more minutes. Okay, does this make sense? Does this answer the questions about the diagnostic process and go ahead?
Ordered in importance, or is it just random?
I mean, so your primary care is going to start things off, so they can do blood tests, they can do the physical exam, the medical history, those kinds of things. Yeah. To do genetic testing, you have to go to, a specific place for that, brain imaging, things like that. So you start with the primary care provider, and they do everything that they're able to do, and then now I will say, well, let me finish this thought, and then you'll be referred to one or a couple of these to continue on those tests. I will say not everybody will get a diagnosis. 50%, if I remember my statistics properly, 50% of people with dementia receive a diagnosis, and 50% of those people, which is what, 25%, are actually told of their diagnosis. Yeah. So many times somebody may have a diagnosis is in the medical record, and maybe they were told, but they don't remember, or nope, they were never told, because the provider doesn't want to tell this horrible news to that person. I mean, years and years and years ago in the 50s, this is how we treated cancer, is people weren't told they had cancer.
Right.
Because providers were worried they were going to harm themselves, they were going to develop depression.
Right.
So it's best for them not to know, because at that point there was nothing they could do about it, right? There weren't the advances that we have now. Dementia is still very similar to that in the diagnostic process. It's a whole nother discussion. But anyway, so there's sometimes people are not going to get, you can't get them to the doctor because they're so in denial. I don't have any problems. You're the problem. Leave me alone. What do you do in that case? I think it's safe to assume they have a type of dementia, and you just do your best. And as somebody who's supporting that person, you learn as much as you can about the disease process. You get support so that you can then support that person. And Christy's going to talk about that a little bit next week too. She's going to start talking about resources and supports. Okay? Medications. I'm going to talk medications. So we had a question already about it. These words are all as bad as my last name, right? These are crazy. Okay, so let me come over here. These are medications that are FDA approved. So first you have the drug name, the brand name, same thing. We just like to have a couple different names for things. So donepezil and Aricept are the same. Galantamine and Razidine are the same, okay? Then we have the type of dementia it's indicated for, or it's approved for, and then when it became FDA approved, and then that tells you at the end kind of what they do. So, these guys, these four, are what we call cholinesterase inhibitors. So I'll back up. All of these medications, none of these delay or slow down the disease process. None of these impact the progression of the disease. What these do is these treat cognitive symptoms. So all of these help those neurons to fire and communicate and send messages, okay? So cholinesterase inhibitors inhibit the breakdown of acetylcholine, which is a very important chemical messenger in your brain for your neurons to be talking to each other, okay? So these kind of stop that breakdown of acetylcholine so that your brain can still communicate, okay? And then you have Namenda or memantine, which is a glutamate regulator. So this regulates glutamate, which is another chemical messenger in the brain. So they're all kind of designed to help your brain keep firing and sending messages and communicating. Okay? So usually what I see is folks will start with a cholinesterase inhibitor. Donepezil is probably the most common. But if somebody can't tolerate Aricept or Donepezil, it's usually they have gastrointestinal issues, so they can go to rivastigmine or galantamine. See how these just roll off my tongue? It's because my last name's Netarostic. I got these, right?
That's progress.
There you go. There you go. So Exelon or rivastigmine also comes in a patch form. So if a person doesn't tolerate taking pills very well, or why am I taking pills? I'm not sick, that argument with a person with dementia, then you can do like a patch. That can be helpful. So usually what I see is the person will start with a cholinesterase inhibitor, and then as the disease progresses, they'll add on memantine or Namenda. So you can see that these are approved mild to moderate, and then moderate to severe. This combo has been so common that they just made a combined drug that came out about 12 years ago. And that's Nemzaric. So that combo is so popular that they just said, okay, we'll put it together for you. Okay? So that's how these medications work. So they're helping your neurons to continue to fire and send messages so that you can process information better, you can make sense of the world around you a little bit better, those kinds of things. Make sense?
Every one of those says Alzheimer's,
Very good.
so they don't work with other forms?
They're not meant for other types of dementia. Some of them can be used with other types of dementia, but there are types of dementia that you don't want to use these with. So it's best to consult your provider, but you hit the nail on the head. The vast majority of the research that we have about dementia is about Alzheimer's disease. The vast majority of all these medications are for Alzheimer's disease. Yeah. Yeah. So all my friends dealing with these other types of dementias, they're just waiting. They're waiting. Yeah. Good catch. These are the medications that actually are FDA approved, and they change disease progression. These are our first medication. Well, there's one medication that came out before this, but now has become unapproved by the FDA because there were so many issues. But these are holding strong. So these are what we call anti-amyloid antibody IV infusion therapies. Right? Okay. Right? No, I won't. Okay. So these are given by IV. Okay. I believe lecanemab is every 2 weeks and donanemab is every 4 weeks IV infusion. So to access these, you have to there has to be a center near you that does this. These are only for folks with mild, very early stage Alzheimer's disease or mild cognitive impairment, which can be a precursor to dementia. Okay, so very, very, very early stage.
Can I start it now?
Good question. Good question. Your insurance wouldn't cover it. I know. These are about $26,000 a year.
How often do you know if the VA covers something like that?
I think they might. Yeah. But again, early stage. Now, these are our first medications that are what we call disease modifying. So what they do, I'll tell you. What they do is during this treatment, the plaques, the beta amyloid plaques in your brain are kind of like sucked out. So it's really, really cool. So because the plaques are removed, it's actually considered that we're slowing down the progression of the disease process. So it's very, very interesting. Now, what happens in the brain when we remove something from your brain that was there, You have this empty space now where that plaque was. So what tends to happen is it gets filled with fluid, and then can cause what we call ARIA. And this is, so usually what we will see, I can't tell you what ARIA stands for right now. I can't think of it, but I'm not going to try. So what will tend to happen, headaches, swelling, those types of things, because of that kind of shift in the brain. But it's very, very cool. Okay? Now, there's other medications if somebody's dealing with behavior issues or something like that. There's other medications that can help with hallucinations or delusions or those types of things. But these are strictly for the cognitive symptoms, and then these are our first disease-modifying medications. So it's very cool. And more medications are coming. We've been testing these forever. Or studies have been leading to this forever, right? So chances are, like what researchers are thinking is that we're gonna end up with a combination of like medications and devices that will kind of attack this disease process, very similar to how we deal with cancer or AIDS. Just kind of, it's not going to be probably one pill that does it, but a combination of things. In addition, risk reduction strategies. So let's talk about risk reduction next. Are we still, I don't even know, is it 10 o'clock yet? 5 minutes. Okay, 5 minutes. Okay, this page is going to be the last one that we're talking about. But let's talk about risk factors. So I mentioned before, age is your greatest risk factor of developing dementia, specifically Alzheimer's disease. Okay? The older we get, the greater our risk of developing dementia. At 65, your risk doubles every 5 years. Okay? Also, family history. So you're doing the math, right? Family history. If you have an immediate family member, so a parent or a sibling with dementia, you have an increased, specifically with Alzheimer's disease, you have an increased risk of developing the disease yourself. But it's not a guarantee, you just have an increased risk, okay? And then genetics. So we have two types of genes. We have risk genes that increase your risk of something, and then we have deterministic genes that determine you're going to get that disease, right? The vast majority of dementias, in the risk area. So I would say 1 to 2% of dementia cases are caused by genetics, by those deterministic genes. So very, very rare. But there are some families where it absolutely runs in the family. That's typically your younger onset types of dementias, okay? The majority of dementias are caused by these risk genes. So we each get a copy of APOE from each parent. So we get one copy from mom, one copy from dad. If you get a copy of an APOE E4, that increases your risk. If you get two copies, one from each, of APOE E4, even greater risk. And I think APOE E2 is a protective version. It's E2 or E3. I think it's E2. But anyway, so you can see how you can have a greater risk because of age, family history, and genetics. Now, these are factors obviously we can't change. We're dealt what we're dealt. Okay? Let's talk about what we can change. This is what we have a say in. Physical activity, healthy eating habits, heart health. What's good for there's a strong heart and brain connection. So what's good for your heart is good for your brain. Getting good sleep hygiene, not smoking or stop smoking, excessive alcohol use, we don't want to do that. Your education level, hearing loss, vision loss, social isolation, and head injury. These all can increase your risk. Go ahead.
How do you feel about supplements like omega-3s and things? Is there enough research there to say those are a good preventative?
You know, it's hard because vitamins typically aren't they're not FDA approved. And so like researchers or nobody's putting lots of money into researching those because they're not created the same every time. You know, you could get an omega-3 over here and an omega-3 over here, and they look very different. What the ingredients are very different. I've had a provider tell me it's just an expensive. It's an expense that you don't need.
I just
So-
totally disagree with that, but,
That's totally fine. That's totally fine.
yeah, that's not your opinion.
Yeah. I will. So it's hard. Like I can't give you any research to back that. But fish oil, yes, things like that can absolutely be helpful. So as far as like diet, the healthy eating habits, what we recommend is the Mediterranean diet. So that tends to be higher in fish, no red meats, that kind of thing, right? I know. The red meats are so good.
And if you're allergic to fish? what
Oh
are you supposed
no!
to do?
Then you take the fish oil. Well, can you take the fish oil? You can't. You can't. Oh no. Okay.
No fish, no dairy.
Oh my gosh. That's a good question. That's a good question. So what is recommended is the Mediterranean diet or the DASH diet. So the DASH diet is dietary approaches to stop hypertension. That's what that means. But then you also have the MIND diet, which is a combination of the Mediterranean and the DASH diet. And it's the Mediterranean DASH intervention for neuro something like that. But it's the MIND diet, MIND. I can't remember what it stands for. So, okay, a lot of people usually question the hearing loss and the vision loss. So if you think about it, if I have hearing loss, I'm not taking in all this input that somebody who doesn't have hearing deficit is. So there's not as much activity or exercise of my brain because I'm not taking in as much information. Also, folks with hearing or vision loss with these sensory deficits tend to withdraw from social situations because I can't follow the conversation or I can't enjoy whatever this is, and so they just stop going to things. And social isolation is a risk factor, right? So it's all connected. So, okay, this is a study, was published in the Lancet, that talks about we're at time, oh my gosh, I'm so sorry. I'll get through this really quick. I think we've got like 4 more slides, but they're all related. So depending on, and I'll break this down on different slides, but this shows you over the course of a lifespan where, if you make specific interventions, where they make the biggest impact as far as reducing your risk of dementia. Okay, so if you do all of these things, studies have shown that we can reduce 45% of dementia cases worldwide. Let's look at what this I can't see it, so I gotta come over here. So at midlife, which is 18 to 65, if we address hearing loss and eliminate that as a risk factor, we can reduce 7% of dementia cases.
Just with reducing hearing.
Just with reducing hearing loss. You heard me right. See what I did there? Okay. High LDL cholesterol, 7%. Depression, traumatic brain injury, 3%. If we can address those and eliminate those as risk factors, we're reducing 3% of cases. Physical inactivity, diabetes, smoking, hypertension, each 2%. Obesity and excessive alcohol, 1% each. Midlife, okay? Then we have early life, less education. If we can address that, we can reduce dementia cases by 5%. So this is in early life, so this is under the age of 18. Okay? That's where that makes the biggest impact. And then late in life, so 65 plus, social isolation, 5%, air pollution, yep, 3%, visual loss, 2%. So again, if we can address all of these at those specific points, I feel like I'm holding my head so weird so I can get this up here. Anyway, sorry. So if we can address all of these, we can reduce dementia cases by 45%. So here's your last page. This is my last slide, I promise. Well, then my name, but this is it. Okay? These are your 10 ways to love your brain, 10 healthy habits for your brain. This is what you can do today to start making a change. So let's talk about these. Challenge your mind. Be curious. Learn a new skill. Learn a new language. Take up knitting. I don't know, something. I had a friend ask me about going to learn how to do mahjong. Like, I don't have time for hobbies. I don't, but I need to do that. I need to learn new things, right? Stay in school. You don't all have to go enroll in school right now, but this counts. This is learning new things. You just took an instructor-led course, right? So do more of these. And Sarah's got all of them, okay? Protect your head. Let's be smart. If you're going mountain biking or off-roading, wear a helmet, okay? Look around your home. For older adults, the vast majority of injuries come from falls. Head injuries come from falls, okay? So trip hazards like this thing, rugs, loose rugs, all of those kinds of things. Take a look around your home. Control your blood pressure, watch all of your numbers. Eat right, I told you the MIND diet, the DASH diet, the Mediterranean diet. Be smoke-free or quit smoking if you are smoking. I know it's easier said than done, but do your best. Manage your diabetes, maintain a healthy weight, move, get moving. You don't have to run marathons, just move. And then sleep well. Sleep has become something that folks are really, really focusing on the last several years. Good sleep hygiene. Okay? Because your brain, that's how your brain clears everything out. So if you're not sleeping well, I don't sleep well. I don't do this. Yeah. So there's another good one. Okay? So you got your sheet, and if you want to learn a new language, it's in Spanish on the back. So everybody learn that. Translate it at home. Oh, there you go. Merci beaucoup. Okay, last, this is just, if you want to reach out, if you have questions, you can reach out. But Sarah, Lisa, Amy, they're your main folks here that are amazing. And they can also help to answer questions. Okay? We're so beyond time, I'm sure.
As we wrap things up today, sorry, I'm just going to talk really loud.
Oh, you want this?
Please, as you exit, take a look at some of the material we have up on the table. The Alzheimer's Association is a great, is a great resource. They have a 24-hour hotline, and it's not just for problems. If you want questions answered, call them. It's not just for emergency situations. And so grab one of those. The National Institute of Health and National Institute of Aging put out some great material that we've got some copies of. And then all of those things that Kate mentioned about preventative steps you can take, all of those could be addressed by attending our senior centers. We've got yoga classes, exercise, aerobic classes, we have art classes, we have computer classes, we do educational classes for caregivers, we have an exercise room, we provide a lunchtime meal that's nutritionally balanced and checked by a dietitian. And the senior centers are for anybody 60 and over. And if you need to bring your loved one or accompany them, you can talk to the center staff, so you could talk to Amy, Shirlene, and Kristen. But there's always a lot going on. Almost all those preventative measures can be addressed through our senior centers and through our aging services. And if not through our aging services, like the smoking cessation is done through the health promotion group here at the health department. And so know that there are resources locally to support you in having a healthy brain and also taking those preventative measures. And then we're here to support those of you that are caring for family members. But please grab some material, and we hope to see you next Wednesday, same time, 6 o'clock. And the presentation will address behaviors that are common with those that are living with Alzheimer's and how you can respond to them. And so we encourage you to come next week. And as Kate mentioned, The person presenting next week is Christy Russell, and she also will be coming from the State Health Department. So again, a statewide expert that we're excited to have come out to Tooele County to speak. So we hope you'll be able to come again next Wednesday too. And if you have any questions, Kate will be here, Lisa, and I would be happy to answer any questions as you're getting ready to go. But please grab any other material. Thanks for coming.